Hello, my name is Morgan. I will be performing my head-to-toe assessment on Mrs. Love today, my patient. So before I begin, before entering my patient's room, I'll just clean off my stethoscope and make sure I keep everything aseptic and clean in between using with other patients. So I'm gonna go ahead and knock, provide privacy, perform hand hygiene, and introduce myself. Hi, Mrs. Love. My name is Morgan. I'll be your nurse today. And today we'll be doing a head-to-toe assessment along with a maternal assessment on you. Now, can you tell me your name and date of birth? Awesome. And I'll be checking her level of consciousness, making sure that she's oriented to person, place, time, all of that. So can you tell me your name and date of birth? Perfect. Now, do you know where you're at? Do you know why you're here? Do you know what day it is? Do you know who our president is? Perfect. All right, so she's oriented, she's alert, she's happy. So I'm gonna go ahead and put my gloves on, but while I'm putting my gloves on, I'll just explain that I would be taking her vital signs. I will initially take her blood pressure. I wanna look, is it within normal range? Is it elevated? If it's elevated, does she have a history of preeclampsia or eclampsia, or did she have preeclampsia or eclampsia during her pregnancy? What are we doing to control the hypertension and prevent seizures? I want to check her pulse, whether it's elevated, low, within normal range. If it is elevated, that could be a potential sign of, or a late sign of hemorrhage. Now, with hemorrhage, you will see elevated pulse and decreased blood pressure. So kind of keep an eye out for that, but hopefully she won't be in that position. Hopefully we can prevent it before then. So I checked her blood pressure, pulse. I want to assess respiration rate, make sure it's within normal limits of 12 to 20 breaths per minute, as well as checking the depth, the rate at which she's breathing, if she needs any, using any accessory muscles, if it's labored, etc. I want to assess her temperature, if it's elevated, anything like that. Check her blood pressure. Her pulse ox. I want to check her oxygen saturation, make sure she's properly oxygenated, as well as her pain. So I'm going to ask her, Miss Love, do you have any pain today? And if so, what would you rate it on a scale of 0 to 10? 0 being no pain and 10 being the worst pain you've ever felt. Where is it located, and does it radiate to any other areas? And what's the quality? Is it dull, achy, sharp? Okay, awesome. And is it intermittent or continuous? Okay, so I just kind of want to get the qualities of the pain, kind of just assess, see where she's at. So now that I've done that, I want to start my assessment. So I'll begin by feeling her head. Do you have any pain or discomfort as I'm doing this? So while I'm feeling around, I want to feel for any swelling, I want to feel for any lesions or bumps, I want to assess her hair. So next I'm going to look in her ear. Look for any lesions, any abnormalities. I'm going to check behind the ear and do the same for this side. And now while I'm checking her ears, I want to snap or maybe whisper a little thing into her ear and have her react. So when I'm snapping, if I snap on her left, have her raise her left arm. On the right, raise the right arm. I just want to make sure cranial nerve 8 is intact and that she can hear. Now I want to assess her eyes. I'm just going to scooch her over. While I'm assessing her eyes, I'll keep my finger right in front of her and have her look in my eyes, or look at my finger, have her eyes look at my finger while I'm checking her pupils, whether they constrict or dilate. I'll have her look at my pen, follow the pen, good, and follow the pen to your nose. And I will also pull down the lower eyelid to make sure that the conjunctiva is pink and moist as the mucosa should be. And so now we check cranial nerve 3. I want to look at her nose if there's any drainage. I want to look at her mouth, so have her open her mouth, stick out her tongue, make sure it's pink, moist, no lesions or bumps, and if there is, we'll note it. I'll have her smile, puff out her cheeks, and stick out her tongue. So cranial nerve 7 is intact. Now shrug your shoulders. Awesome, and cranial nerve 11 is intact as well. All right, Mrs. Love, I'm going to have you push and pull against my hands, and I want you to squeeze my fingers. Awesome. And we're just kind of checking musculoskeletal system. If she's been walking, assess her gait. If not, if she's had an epidural or other medications, she may or may not be walking, but we do want to have her moving at some point just to kind of reduce the risk of a DVT. So now that I assess the top portion, I want to go ahead and listen to her heart, and I'm going to do ape to man. So I will listen to her aorta, the pulmonic, tricuspid valve, Erb's point, tricuspid valve, and mitral down here. So after listening to her heart, I will assess cap refill on her fingers, and as I make my way down to lower extremities, check her pedal pulse, and I also want to check her radial pulse. Good. Now I want to check skin turgor, make sure that there's proper hydration. Next, when I was checking her respiratory rate, I was also looking at depth, rate, and whether she was labored when she was breathing, anything like that. And the left side has 2 lobes, and the right has 3. And I'll just listen into about 6 different areas. On the front, I'm going to have her take a deep breath in and out. And we're not going to go too fast because I don't want her to get lightheaded or short of breath. So after listening to that, so because I'm doing a maternal assessment, I'm going to go right to the breasts and nipples and work my way back down to the bladder and bowels as you typically would do with a normal head to toe. So for the breasts, I'm going to check, are they filling, are they soft, are they engorged, tender or non-tender, are there any blisters or redness, cracking? I want to look for all of that. I want to look for signs of mastitis, or if it's normal, if her breasts are normal and healthy. I will also want to educate her on signs and symptoms to look out for mastitis. If she's breastfeeding, I want to give her any interventions or management tips that she could do to make sure that she's comfortable and that baby is getting the proper nutrition that he should be getting, as well as if she is bottle feeding, wearing a supportive bra. I want to make sure that she knows different interventions to make herself comfortable. So assess the breasts. Now I want to go to uterus. So Miss Love, I'm going to lower the head of the bed, have you lay down, put your feet on the bed, and have your knees up. So she'll kind of be laying down with her knees up. And I want to hold the uterus at the base of the pubic bone right here and cut my top hand, and I want to feel, is it firm or boggy? If it's firm, that's good because it's contracting down. If it's boggy, that's not good. We need the uterus to contract down to prevent hemorrhage. Now, as I'm massaging and palpating, I also want to assess the lochia, see if there's any drainage coming out and how much. I want to check where it's located. Is it located at the umbilicus or is it above and below? And if it is above and below, by how many centimeters? Sometimes after birth, it could be a little bit below the umbilicus just because the birth canal muscles are expanded or weakened. So as it starts to tighten up, then the fundus should return to the umbilicus level. Is it skewed to the left or right, or is it midline? If it's skewed to the left or right, has she emptied her bladder? And if not, then I want her to empty her bladder and see if it returns midline. Now from the uterus, we'll go right into bladder assessment. For her bladder, I want to know, are you peeing spontaneously? Have you gone pee within 6 to 8 hours of vaginal delivery? Sometimes epidural may cause urinary retention, so if she's not able to pee, we want to get a catheter in there to release the urine, because if there is urine, it will make it go left or right, the uterus to fall left or right of midline, and it will also restrict the uterus from involution. So we just also want to know, how frequent is she going? Is there any burning or urgency? Because that could be a sign of a UTI. And just ensure that her bladder is being emptied. Now I want to check her bowels, and I'll kind of assess for any abnormal distension. I want to listen to all 4 quadrants. Am I hearing bowel sounds? How active are they? When was her last bowel movement? And what was the quality of the stool? And what was the quality of the stool? Is she able to go? And now since I'm down here, I want to look at the incision site if she had a C-section, and I want to assess for any redness, ecchymosis, edema, drainage, and the approximation of the suture site. And C-section. If they had a C-section, you may hear some flatus. Okay, so breast, uterus, bowel, bladder. Now I want to assess lochia. What is the color? Is it lochia rubra, serosa, alba? Typically we'll see serosa as soon as she's given birth. C-section patients will have less amount, typically, of lochia, just because in the C-section I believe that they're able to take out some of the inner lining of the uterus, and kind of that's what causes less shedding, less amount needing to shed. You want to assess amount, obviously, if it's scant, light, moderate, or heavy. And odor, is there an abnormal odor? If so, that could be a sign of infection. Now with the amount, if she's having an excessive amount of bleeding, I immediately want to assess the fundus. If it's boggy, I want to start massaging and call for help, because that is a sign of a hemorrhage. And any abnormal bleeding I want to note, and I want to alert people immediately, because it could be caused by retention of the placenta, uterine atony, any lacerations, or even a hematoma. So now that we assess the lochia, I want to have her go to her side, and I want her to lift her leg up so that we can assess her perineum area, her perineal area. So I want to assess the episiotomy. I want to look for any redness, edema, ecchymosis, drainage, or the approximation of the suture site. If she's having any edema or pain or maybe uncomfortability, we could give her a cold pack just to provide some comfort. I want to check the perineal area, see how that is, and look for any hemorrhoids. I want to check the epidural site to make sure it's healing well, that there's no redness, bleeding, drainage. Just make sure it looks healthy. Lochia, episiotomy site. So now I'm going to go to her lower extremities. I'm going to look at her calves, check for any redness, swelling, edema, pain. I'm going to kind of palpate to feel if she has any, to see if she has any discomfort. If she does, that could be a sign of DVT with the redness and swelling. So I will not perform Hohenstein. If there's no indication of a DVT, I could perform Hohenstein. I also want to check the push and pull of her feet. I want to assess the pedal pulses and cap refill, skin turgor, and for any lesions. So after checking that, I can sit her up and I'll ask her about how she's adjusting to motherhood, if she's happy, sad. I also want to assess what phase she's in, whether that's taking in, taking hold, or letting go. And kind of assess the interaction of the family with baby, her and baby, if it's appropriate or not, and make sure everything is doing well, and just educate along the way and be as helpful as possible as they transition into life with this new child of theirs. So that's my head to toe with a maternal assessment, and thanks so much.